So this is our hospital, Baylor Scott the Heart Hospital, Plano, Texas. It's again, I didn't mention that I'm the Intervascular Fellowship Program Director in our hospital, and it's radial to peripheral is something we teach our fellows early on to go to the world and kind of spread the knowledge. So I'll start with this case, and I have a couple of cases going from the iliac all the way down to the popliteal, and this is a 67-year-old female, has history of diabetes, hypertension, and she basically came with a bilateral claudication, and her ABI is showing bilateral abnormality, worse on the right side. In a different hospital, they tried an attempt to fix it via bilateral common femoral artery access, and unfortunately, the glide wire has crossed the dissection all the way to the distal aorta, and they could not re-enter at the bifurcation level, so they aborted. And the question is, what option do you have? And I think all those options are a reasonable option. You can reattempt the femoral access and maybe try to get a recrossing device. If young patient are low risk for surgery, I think surgery is also an option. Treating with medication alone, I think, she was treated with medication and walk-in exercise and she fails. And of course, others, we're talking about radial. Um, so this is her angiogram. You can see an occluded right common iliac artery in the left. Maybe there's a 90% lesion. We're able to cross single access. This is a IVL shockwave. I think that was a 7x60 M5 plus. And then basically we deployed a balloon expanded stent. And really the only balloon, the largest balloon expanded stent you can do from the radial is the 9x19. I think that's from Abbott. But 8 by any length can be available. And then the other side was much easier to cross. And when we took selective pictures, what we noticed in the selective picture, the distal aorta was not involved, and there was a nub on both common iliac to landed right in the common iliac. And so if you notice on the left side, we did a balloon expanded stent. I think that's 8x57, if I'm not mistaken. And this is your final result. You have them placed right next to each other, and you have a successful intervention. I mean, the point of this case is that you can do this from a single access. If you still need to do another access from the contralateral leg, I think that's reasonable. We've had a couple of cases where we did bilateral radial. It just become inconvenient from a procedure
Yeah.
perspective.
Yeah.
But just an example, distal aortic, we always get radial access, but we just have a better chance going distal aortic crossing.
Now, you mentioned you did use shockwave in this
I
case?
use shockwave on the right side, correct. So the shockwave, the
Okay.
M5 Plus is a 135 shaft, and this is
Okay.
what became a game changer. The M5 was, I think, 110, and we had an issue there. But again, this case where we put a 105 sheet that's landed in the distal aorta, we had a 135. We really didn't know. We didn't do any. The only equipment here that we did a radial equipment is the sheet. It's
I
a
see.
traditional wire, traditional balloon, traditional shockwave.
Yeah.
And it's all reached because you use the 105. If you use a 150 or 119, you get limited on some of the options.
I gotcha. Yeah, just because you going back to you were mentioning the limitations before and what you wish you had, it was just basically a longer shockwave catheter, right?
I think long IVL for the SFA and the popliteal will be a game
Yeah.
changer.